I doubt that many of us lie awake all night thinking about our lymph nodes. However, we are all called to scan lumps and bumps throughout the day and throughout our careers as sonologists and sonographers. And as it turns out, many of these lumps and bumps actually wind up being lymph nodes, normal and abnormal. Well, in this section, we will talk about the secrets of the lowly lymph node. First, we'll begin by studying the anatomy and physiology of the normal lymph node. From there, we'll look at reactive lymphadenopathy. And then we'll go on to a section about those lymph nodes which are truly abnormal, which have cystic lesions or microabscesses or abscesses associated with them, or even calcifications. And last but not least, we will look at the malignant lymph node. So come with me now as we venture in this section, and we will unlock the secrets of the lowly lymph node.
First, let's consider the anatomy of a normal lymph node. A normal lymph node has a central medulla or hilum, which consists of fat and connective tissue and vessels. It's also relatively hyperechoic to the peripheral cortex, and the hilum also has a feeding artery and vein. Also important is the fact that the length and the width of the lymph node is usually 2 to 1. In other words, a normal lymph node is generally twice as long or more than it is wide. The shape of a normal lymph node is generally ovoid, and as mentioned on the previous slide, it is generally 2 times longer than it is wide. If you use a little bit of imagination, you might think that the lymph node actually looks a little bit like a kidney. Here again, you see a lymph node which has its normal oval shape and is approximately 2 times 1 longer than it is wide. You can see the echogenic hilum and the hypoechoic cortex. As you might suspect, there can be a variation in the anatomy of a normal lymph node. There should always be a hyperechoic hilum surrounded by a less echogenic or hypoechoic cortex. The size of the lymph node is less important than whether it's changing in size and whether it maintains its 2 to 1 relationship between length and width. People have suggested that there is a normal or maximum length for cervical lymph nodes, which is approximately 7 millimeters in length, or 9 millimeters in length for the inguinal nodes. Understanding the vascular pattern in lymph nodes is important in discerning whether they may be normal with normal flow, reactive with increased flow, or malignant with ectatic flow. A normal lymph node will have one hilum, and the artery and vein and lymphatics will enter the lymph node from that hilum and spread to the rest of the lymph node in a relatively regular pattern. On the other hand, malignancy causes blood vessels to enter from the periphery, and there may be more than one blood vessel entering from the periphery of the lymph node in a rather disorganized fashion. Here we can see normal color flow into a normal lymph node. Although the internal architecture of the lymph node is not well seen in this example, you can certainly see the central artery and vein entering from one position on the lymph node.
Now that we've had a little bit of time to discuss the normal lymph node, its length versus its width, its size and the limitations of size, the location of the cortex and the hilum within the lymph node, and the way the blood vessels enter into the hilum, and the color flow Doppler characteristics of normal lymphadenopathy. I think we're ready at this point to begin looking at abnormal lymph nodes, and we'll talk first about the reactive lymph node. However, I would like to say before we go on that while ultrasound is extremely helpful in limiting the differential diagnosis of lymphadenopathy, still it cannot make a pathologic diagnosis. For that, you're either going to need bacterial culture or a fine needle aspirate and a pathologic diagnosis. Ultrasound probes are getting very good and the resolution is great, but still it can't make a pathologic diagnosis.
Reactive lymphadenopathy is considered to be benign and reversible. It's usually due to an immune response or to an infection or a pathogen. These are big nodes that are often palpable and tender to palpation, but on ultrasound they maintain normal architecture. However, on occasion, reactive nodes may also demonstrate some rather bizarre internal architecture. Reactive lymph nodes can actually be quite large, up to several centimeters in length, but usually they maintain their normal length to width ratio. Reactive lymph nodes may demonstrate increased vascularity, as in this case, but always from one central location and always going to the hilum. Well, there are lots of places that we can scan nodes. Certainly cervical lymph nodes are very easy to scan. And you'll find that supraclavicular nodes are also easily acquired by ultrasound. Axillary nodes are superficial, very easy to see, as are inguinal nodes. A little later on in this video, we'll show you how to appropriately image the pelvic or abdominal or peri-aortic nodes. This is a young man that I was asked to scan who actually had quite an interesting past medical history. He told me he had had this lump under his axilla for several weeks and didn't know what it was. But he also told me that he had a past medical history of pulmonary tuberculosis. He had told me that the tuberculosis had spread into his neck and he had cervical adenitis and had to have a surgical resection of his lymph nodes, thus the scars in his neck. The question that I got was, is this recurrence of his pulmonary tuberculosis? And indeed, is it adenitis secondary to tuberculosis? Well, if you look at the lymph node, you'll see that it is rather plump and quite large. If you look at the markings on the side, you can see that it is probably 4 to 5 centimeters in length, far more than the 7 to 9 millimeters, which would be considered normal. And it doesn't really follow that 2-to-1 ratio. However, it does have a nice hyperechoic hilum. If you look superior on the lymph node, you'll see that there's some hypoechoic areas which either represent cystic changes or indeed necrosis or early abscess formation. Unfortunately, there's nothing about this lymph node that tells me whether it's tuberculous or not, but it certainly is an abnormal lymph node. I think for any of us scanning this patient, it's incumbent upon us to either repeat the scan in a day or 2 or 3 to make sure that these are not small micro-abscesses, which will develop into a larger abscess. And of course, we don't have a tissue diagnosis, so that needs to also be addressed. Well, when I'm not busy doing ultrasound scanning in the developing world, this is where I work. I work in a university pediatric emergency department, and this is what my normal patient looks like. This is a young girl that came in with a high fever and swelling in the right side of her neck. And I was asked to see if she might have cervical adenitis or an abscess. And she's giving me that look like, you're not coming near me with that ultrasound probe. Well, this is the ultrasound of the right side of her neck. And cervical adenitis is really one of the exceptions to the rule. You can see these are large lymph nodes. They're irregular. They have no central hilum. And they have some small hypoechoic areas within them that either represent cystic changes or necrosis or early abscess. Ultrasound has been extremely helpful in the diagnosis and management of cervical adenitis. As we said before, that these lymph nodes in the neck can be quite bizarre and break the rules for what we see as normal versus reactive and abnormal lymph nodes. The little girl in the previous slide, although she was quite difficult to scan, did well on oral antibiotics and was sent home and was seen back in a day or so and was much, much better. On the other hand, this child looked to me almost identical to the other little girl with swelling on the right side of the face, but this child actually wound up having an abscess from the cervical adenitis and had to have an admission for IV antibiotics and eventually drainage of the abscess. Sometimes we need to get a little creative with our scanning. This is a child who came in with swelling of the left side of his face, and I think you can kind of appreciate it there. He was also tender, and he screamed and yelled and held on to his parents. He was adamant that he was not going to be scanned. However, I showed him how to scan using my own face and gave him the probe, and he was quite happy to scan, and I got relatively good images. As you can imagine, this is not cervical adenitis, but this was an enlargement of his left parotid gland. We are often called upon to scan lymph nodes in the neck, and where I work in a busy university hospital pediatric emergency department, my experience is most of these are just enlarged, tender, reactive lymph nodes, probably secondary to viral infection or strep infection of the throat or viral pharyngitis. Although we also do see a fair amount of cat scratch fever secondary to Bartonella insulae. In a little bit older child, we often will find reactive lymphadenopathy secondary to mononucleosis or Epstein-Barr virus. And of course, you're always looking for that child with lymphoma. But that, of course, depends on your location. If you're in a high incidence area for HIV, you may actually be seeing lymphadenopathy secondary to acute HIV disease, although you may not know that unless you have a positive HIV test. And of course, you're always on the lookout for scrofula or Mycobacterium tuberculous lymphadenitis of the neck when you're scanning in areas with HIV or high incidence of TB. The man in the bottom photo came in for what I thought was an abscess or lymphadenopathy, and it actually turned out to be an enlarged salivary gland. This is quite an angry looking node in the neck of a child. You can see there's nothing in this node that looks normal. There's nothing that even looks like a reactive lymphadenopathy. The node is quite large. It goes from about 0.5 to 2.5 or 3 centimeters, which makes it greater than 2.5 centimeters from top to bottom. You'll also notice that the node itself has mixed echogenicity as well as increased blood flow within the node. There's a rather obvious hypoechoic area in the node which represents either cystic degeneration, necrosis, or early abscess formation. Intranodal necrosis or hypoechogenicity is always pathologic in a lymph node. Now I know what happened to this child. It actually wound up being cervical adenitis, but you certainly can't tell that from the lymph node. In areas where there's a lot of tuberculosis, if this lymph node had calcium deposits in it, you might consider tuberculosis, but of course this lymph node does not have calcification. Here are some examples of tuberculous lymph nodes. These lymph nodes are ill-defined, they're hypoechoic, they have no distinct central hilum, they have irregular borders, and unlike normal lymph nodes or reactive lymph nodes, which have sharp borders, these don't have distinct sharp borders.
Now, it would be extremely helpful for a sonographer to be able to look at a lymph node and decide whether or not the lymph node was from tuberculosis or not. It's very difficult sometimes to make the diagnosis of extrapulmonary tuberculosis, and it would be very helpful to be able to scan a lymph node and be able to make that diagnosis. It would also be very helpful in patients with pulmonary tuberculosis who are smear negative if we could scan a lymph node and make the diagnosis of tuberculous adenitis. Well, that's the exact question that the authors of this article addressed in the Journal of Ultrasound in Medicine. This was Park and Kim in September of 2014, and these are their images. What they asked was, are any of these images, which are considered classical for tuberculosis, specific or sensitive enough to be able to make the diagnosis of tuberculous adenitis? And these are all cervical lymph nodes. There are 4 images here listed A, B, C, and D. Let's look at them individually. The image listed A shows a node which is generally hypoechoic but has some intranodal necrosis. The image in B shows several nodes actually matted together with indistinct borders between the nodes and some nodal matting and clumping. The image in C shows some hypoechoic areas in the perinodal soft tissue, which represents edema around the node, and the node in D shows how the vasculature is actually pushed away from the lymph node to the external part of the node. The question is, are any of these singularly or in combination specific and sensitive enough to make the diagnosis of pulmonary tuberculosis? Well, there's good news and bad news here. The good news is that most patients with tuberculous adenitis will have the image as shown in A, which is a hypoechoic or mixed echogenicity node with some necrotic areas. And if you pair that with the image in B or C, the likelihood of having tuberculous adenitis actually goes up. So if you have the image in A paired with B and C especially, that you're more likely to have tuberculous adenitis. The problem with that is that most patients with tuberculous adenitis will have these images. However, the opposite is not true. These images don't represent tuberculous adenitis. In other words, in patients with a high likelihood of tuberculosis, if you have these images, it would certainly lead you toward the diagnosis of tuberculosis. However, if you have these images, you cannot say that they are consistent with tuberculosis. So are they helpful? The answer is yes. They have a high sensitivity but low specificity. If they're present in a patient with suspected TB, it is helpful. However, if they're present alone and by themselves, it does not lead you to the diagnosis of tuberculosis.
Let's take a peek now at deep lymph nodes or peri-aortic nodes. To view the peri-aortic nodes, you'll need your abdominal transducer or your curvilinear transducer. You'll adjust it for the depth that you anticipate the aorta. Place your transducer just at the level below the xiphoid process until you see the aorta just above the vertebral bodies. You'll notice the pulsation. Now at this point you can do one of 2 things. You can take that transducer and run it down toward the umbilicus and toward the bifurcation. Lymph nodes will occur right above the aorta and will wink at you as you go past them. You can also turn the transducer longitudinally, which is the way I like to view the lymph nodes, and you'll see what we call the banana peel view. If you see the aorta longitudinally, there will be two branches coming off that look actually like the peeling of a banana. The first one will be the SMA, or superior mesenteric artery. The second one will be the celiac axis. You can scan just above that area, and your peri-aortic nodes will be right above the celiac axis and superior mesenteric artery. This is a banana peel view of the aorta, and you can see it's abnormal. The trunk of the SMA and celiac axis appear to be cut off, and what's difficult to see in this image is that there are small grouped peri-aortic nodes just below the celiac axis. Here's a nice video clip of a banana peel view. You can see both the SMA and the celiac axis nicely coming off the aorta. By the way, there are no nodes in this patient. And you can also see the shadowing of the vertebral column just posterior to the aorta. This was supposed to be a banana peel view of the aorta, but you can see there are so many lymph nodes surrounding the aorta that you can't even see the aorta except for just a small clip of the aorta as we pass through the lymph nodes. The power Doppler shows that these are reactive lymph nodes. You can also see the shadowing of the vertebral column posterior to the lymphadenopathy. The location of lymph nodes can also give you a clue as to what they might be. This is an extremely thin patient, actually so thin that I would call him cachectic, and you can see that there's almost no subcutaneous fat whatsoever. The two layers that are moving in the upper part of the video image are actually the two layers of the peritoneum. The Doppler is on the aorta, and the aorta is completely surrounded by these abnormal-looking lymph nodes. This is a patient that I suspected of having disseminated tuberculosis.
We finished talking about normal lymph nodes, their size, their width, their length, the normal hilum. We've talked a little bit about reactive lymphadenopathy, their size, and the way that they mimic the architecture of the normal lymph node. We've also talked about those troublesome lymph nodes that violate the length versus width ratio and also may have cystic or necrotic or microabscesses or abscesses within them. Now we're ready to move on to the last topic, which is a discussion of malignant lymphadenopathy.
Well, let's consider the architecture of malignant nodes. Oftentimes, malignant nodes are not oval as a normal node would be, but rounded with a length to width ratio of less than 2:1. There's also loss of the normal corticomedullary architecture. In other words, you can't tell the hilum from the cortex. Oftentimes they're hypoechoic, but this is not universal. There's abnormal cortical flow. In other words, instead of one vessel going into the hilum, there may be ectatic arteries coming in from each side, and they may be somewhat jumbled together. There may also be cystic changes, but remember, cystic changes can take place also in reactive lymphadenopathy. Don't assume that all malignant nodes are enlarged. Some are actually quite small or be normal size. And also don't be fooled by posterior acoustic enhancement. Oftentimes when we see that posterior acoustic enhancement, it's a sign that the lymph node is benign. But there are lymph nodes that are malignant and have posterior acoustic enhancement, primarily lymphomas and melanomas. The representation of the lymph node in the diagram shows a very small hilum. Oftentimes, this is a sign that malignancy has infiltrated the lymph node and put pressure on the lymph node so that the hilum actually collapses. On the image on the other side, it looks like there's a fairly normal looking lymph node in the middle. However, you'll see that the hilum is actually pushed to the side, and there are two other lymph nodes, one above and one below, that have no hilum, and one is quite round, although small. This is actually from a patient with leukemia with infiltration of his lymph nodes. This is actually a picture from the same patient with leukemia on the previous slide, but I hope you get a better look at it here. You can see that the hilum in the central lymph node is actually pushed to the side, and also the other two lymph nodes have no hilum, and they're round and not oval. This makes it very suspicious for abnormal lymphadenopathy or malignant lymphadenopathy. This demonstrates the vascularity of a normal reactive node and a malignant node. On the lymph node on your left, you see that it is somewhat elongated, and the power Doppler, which unfortunately doesn't show up very well in this picture, demonstrates a central artery or central vasculature going into the hilum. On the other hand, the malignant node shows that the node itself is round and hypoechoic. It doesn't have a discernible hilum, and has peripheral flow of vascularity into the node from multiple locations. This makes it almost certain that it's a malignant node. This video clip demonstrates many of the characteristics of a malignant node. You can see that the node is actually quite large here. It goes from about 0.5 to 2.1 or so from top to bottom, and I'm not sure how far it is across, but maybe 3 to 4 centimeters. It's also rounded and not oval, and if you look carefully, there is mixed echogenicity within inside the lymph node and maybe even a hint of a cystic area within inside the lymph node. On power Doppler, you see that the blood flow is quite chaotic. With all of these together, the chances of this being a malignant node are very high. This is a video clip of an abnormal lymph node. You can see several things. You can see it has somewhat of a rounded appearance. Also, you can see that you can't discern the hilum from the cortex. Also, with the power Doppler, you'll see that there are actually two areas where the vessels are entering the lymph node, and this is always abnormal. But what I wanted you to see in this particularly is the posterior acoustic enhancement, which is significant. This is actually on a patient with malignant melanoma, and I wanted to demonstrate to you how well melanoma causes posterior acoustic enhancement. Okay, let's see if we can put this all together. Hopefully at this point you all recognize that these are not normal lymph nodes. They are certainly not oval. Actually, the one on the left is actually almost round. There is no discernible hilum and cortex, and if you look carefully, the lymph node itself has mixed echogenicity. There are also some small cystic areas within the lymph node, which may be cysts or microabscesses or necrosis, and as I mentioned before, this is always abnormal. I also did not put power Doppler on these nodes, but if I did, I suspect that they would not have one central artery going into the hilum. You also notice that these lymph nodes have significant posterior acoustic enhancement. As I mentioned before, that many malignant nodes, particularly melanomas and lymphomas, will have that posterior acoustic enhancement. So I think with the information that we've learned, you can all call these abnormal nodes. And looking at the architecture, them being so bizarre and cystic, that we would think very likely that these would be malignant nodes.
We're now at the conclusion of this segment on lymphadenopathy. We've discussed the normal lymph node, its anatomy, where the hilum sits, the length versus the width, and how the blood vessels flow into the hilum from one location. We talked about reactive lymphadenopathy, how these lymph nodes can be very large and somewhat misshapen, but still have a central hilum and have one area where the blood flow goes into the lymph node. We've talked about those troublesome lymph nodes that we sometimes see in cervical adenitis and other diseases that may have areas of necrosis or cystic areas or microabscesses, and how they're difficult to discern the etiology and how some of these, although benign, can look very nasty. And last, we've talked about malignant lymphadenopathy, how oftentimes they have a significant amount of posterior acoustic enhancement, especially melanoma and lymphomas. We've also discussed how they may be misshapen. They don't follow that oval architecture that we see in normal lymph nodes or reactive lymph nodes. We've also talked about the blood flow in malignant lymphadenopathy, where we have neovascularization, where the arteries or vessels may penetrate from the periphery in multiple locations instead of the central area into the hilum, and how sometimes the hilum is misshapen or even non-visible. Well, I hope you'd enjoyed this segment, and I'll see you the next time around.